Hi, everybody. My name is Nate Wilson. I'm one of the residents at UT Houston, and I'm happy to walk you through a case of Budd-Chiari syndrome secondary to paroxysmal nocturnal hemoglobinuria, which manifested with large hemorrhagic esophageal varices. So, quick background: Budd-Chiari syndrome is a rare condition with high morbidity and mortality, which is characterized by hepatic venous outflow obstruction, classically caused by hepatic vein thrombosis. It may lead to sequelae of liver failure, including cirrhosis, ascites, encephalopathy, and varices. And patients with Budd-Chiari syndrome should be evaluated for an underlying prothrombotic condition, including myeloproliferative neoplasms, genetic and acquired hypercoagulable mutations. My patient was a 25-year-old male with no prior past medical history who presented to the emergency department with 1 day of melena, hematochezia, and hematemesis. Upon discussing with him, he reported no family history of bleeding, clotting, or gastrointestinal disorders, no personal history of any gastrointestinal or bleeding disorders, and then he just said that he occasionally used alcohol, but no tobacco, no illicit drug use, and no medications. My initial differential diagnosis for a young healthy male presenting with what I suspected was an upper GI bleed was likely a Mallory-Weiss tear or potentially peptic ulcer disease. So my next step was to assess the patient. He was very lethargic, tachycardic to 106 beats per minute, hypotensive to 74/50, and then he had pretty noticeable hepatosplenomegaly on my exam. Preliminary complete blood count was remarkable for a hemoglobin of 6.9 and a platelet count of 32. So this chart below shows that he was presenting with suspected upper GI bleed with unstable vital signs and labs showing anemia and thrombocytopenia. So the initial step was to resuscitate with IV fluids, start an IV proton pump inhibitor and keep the patient NPO, transfuse for his hemoglobin, and contact our GI colleagues. The next day, they performed an upper endoscopy, which showed very large esophageal and gastric varices, which required 7 bands placed to stop the bleeding. And so that kind of made me take a step back and think, why did this young, healthy patient have esophageal and gastric varices? Likely had some sort of increased portal hypertension from some source. So the next step was, especially given his physical exam findings of hepatosplenomegaly, was to obtain liver imaging with ultrasound, CT, and MRI. And we came to the diagnosis of Budd-Chiari syndrome as these images demonstrated hepatosplenomegaly, cirrhosis, a few reactive ring-enhanced liver lesions, and then hepatic vein thromboses. Here you see the CT abdomen, which revealed hepatosplenomegaly, a very, very large liver especially. And then on the next slide, we can see his MRI, which showed filling defects of the right, left, and main hepatic veins consistent with thromboses, as you can see the arrows showing the filling defects. In other workup for his liver failure, we checked his LFTs, which were all within normal limits. His urine drug screen, alcohol screen, and acetaminophen screens were all negative for any of those sources. Acute hepatitis viral panel was negative, and then a liver biopsy was actually obtained and consistent with chronic venous outflow obstruction, consistent with the filling defects that we found on MRI. The next step to manage his liver failure in the setting of hepatic vein thrombosis was to perform a DIPS procedure, which is similar to TIPS, which is a intrahepatic portosystemic shunt placement, but this is a direct intrahepatic portosystemic shunt placement. And so we connected the portal vein to the inferior vena cava. The thrombi were coiled, and then there was embolization that was performed during this procedure as well of gastric varices. For his cirrhosis management long-term, he's being evaluated for transplant, and he's being surveilled for HCC with imaging and AFP checks at every 6 months. And he was continued upon discharge with lactulose, a proton pump inhibitor, and sucralfate as well, and following with hepatology. Now, the next step, however, is to figure out why he had these thrombosis in the first place. But first, I'll show you an image of the DIPS procedure. So he actually had ultrasound imaging before and after the DIPS procedure. And you can see here on the left, this is pre-DIPS. It showed the pathologic hepatofugal flow of his portal vein. And then after the DIPS procedure, we were able to decrease that portal pressure, and it showed patent hepatopedal monophasic flow, which is as it should be, consistent with a successful procedure. So as I had mentioned, the next step was to figure out why he had formed these clots in the first place. So checking some hypercoagulable tests, the most common is factor V Leiden mutation, antiphospholipid antibody, homocysteine level, prothrombin 22.1a mutation, protein C, protein S, antithrombin, and JAK2 mutations were all negative. Flow cytometry, however, performed, as well as a bone marrow aspiration were performed next. The bone marrow aspiration showed no myeloproliferative neoplasm, but flow cytometry did show a significant clone of granulocytes and monocytes with a GPI deficiency, as well as CD59 negativity or diminished on flow, consistent with the diagnosis of PNH. So the treatment for that, next steps were anticoagulation, as well as initiation outpatient with eculizumab, which I can get to in just a minute, as well as B12, folic acid supplementation, and follow-up with hematology. So altogether, this is sort of the flow chart from presentation to diagnosis and management of his liver failure, as well as the PNH, which led to the Budd-Chiari syndrome. So the differential diagnosis for hepatic vein thrombosis in the absence of other risk factors for provoked thromboembolism is, as I had mentioned, some of these things that we tested for: myeloproliferative neoplasms, polycythemia vera, essential thrombocythemia, factor V mutation, protein C, protein S deficiency, prothrombin mutation, antithrombin deficiency, a 510 methylene tetrahydrofolate reductase enzyme mutation, plasminogen activator inhibitor, hyperhomocystinemia, and our diagnosis was paroxysmal nocturnal hemoglobinuria. Now, the pathology is that it develops from a mutation in the PIG-A gene. It leads to a production of red blood cells with an absent GPI-anchored protein such as CD55 and CD59, as in our patient, which leads to complement-mediated hemolysis and platelet activation. The diagnosis, as we showed, was confirmed with flow cytometry of the peripheral blood, which recorded the deficiency of these GPI-anchored proteins and detected the size of the clone of PNH. The larger the clone, in fact, is more associated with thrombosis formation in PNH. And 1/3 of these patients will develop thrombosis, which is the leading cause of mortality in PNH. The treatment is with a monoclonal antibody which inhibits complement activation called eculizumab, which may improve thrombosis burden, liver failure, and quality of life in these patients. So the take-home points of this presentation is that thrombosis induced by complement-mediated platelet stimulation, fibrinolysis inhibition, endothelial dysfunction, and coagulation cascade activation is the most frequent cause of mortality in patients in PNH. The management includes anticoagulation for the thromboses to prevent further thrombi formation, a DIPS procedure or a TIPS procedure to restore the hepatic blood flow and lower those portal pressures, and then eculizumab to treat the PNH pathology. And it's always important to include PNH in the differential diagnosis for patients who are presenting with unexplained hepatic vein thrombosis and the Budd-Chiari syndrome. So this is a cool case of a rare disorder presenting with hematemesis and large esophageal varices. And I thought it was an interesting diagnostic pathway that we went to. Here are my references, and thank you so much for listening to me.